Good morning. Thank you for joining us for our educational webinar. My name is Dr. Hope Randle. I am part of the clinical team here at Aegis, and today I'll be presenting on the topic of understanding kratom alkaloids in clinical practice. The following material is the property of Aegis and is not intended for reproduction. By the end of this presentation, it is our goal that participants will be able to describe kratom's origins, active alkaloids, and pharmacology, identify clinical effects, side effects, and health risks associated with utilization of kratom products, and discuss current knowledge and approaches for patient counseling and management. Let's start at the very beginning. What is kratom? Kratom is a psychoactive plant derived from the leaves of the Mitragynine speciosa tree, which is indigenous to Southeast Asia. Its leaves are consumed by chewing, smoking, or brewing them into a tea. Kratom has been used for centuries to treat a variety of different ailments, including pain, gastrointestinal distress, and cough, as well as being used to enhance productivity, physical endurance, and even heat tolerance. There have also been case studies assessing kratom as a substitute for opium in managing morphine addiction, though concerns for safety of use have limited widespread utilization of this replacement therapy. More recently, kratom has gained significant popularity in the Western Hemisphere. The Substance Abuse and Mental Health Services Administration National Survey on Drug Use and Health found that 1.6 million Americans reported using kratom products in 2023. With recent rise in popularity and availability of these products, this number has likely grown significantly since that time. Products may be found in a variety of different formulations, including liquids, powders, capsules, crushed leaves, and tablets. Reported reasons for use varied from analgesia to euphoria or relaxation. An additional appeal to these products has been their ease of access, with many being sold in gas stations and vape shops across the country. Product claims suggest improved quality of life for the purchaser, but specific product labeling is often vague. While the name kratom is relatively well known in 2025 and can be seen on many of the products on your screen, the exact chemical components of it are often less familiar. Let's dive into some of the specific components that make up the plant product traditionally known as kratom. Kratom contains over 50 different alkaloids or plant-based compounds, with mitragynine being the most abundant and primary active alkaloid. It accounts for up to 66% of the alkaloid content of traditional kratom. Kratom is metabolized in the liver to form 7-hydroxymitragynine, which is then further metabolized in the blood to form Mitragynine Pseudoindoxyl. These metabolites have similar mechanisms of action with varying potency at mu-opioid receptors, as is detailed in this graphic. These very same chemical structures are now being synthetically produced in laboratories and incorporated into products with strength 10 to 100 times greater than traditional kratom, despite the lack of oversight or safety testing for any of the aforementioned products. Today, we'll discuss some of the similarities and differences between these three chemical compounds and why they're so important to differentiate. We'll start with the primary alkaloid that is traditionally the main component of kratom, mitragynine. Mitragynine is most commonly categorized as an indole alkaloid according to its chemical structure. However, the proposed pharmacology of kratom and its synthetic variants is thought to be multimodal. Kratom acts as an agonist at alpha-2 receptors, producing sedation, hypotension, and pain relief, and exhibits mixed dopamine activity, potentially dose-dependent, which contributes to euphoria, relaxation, and the potential for psychosis. Much of the primary discussion around kratom's mechanism is related to its agonist activity at mu-opioid receptors in the body, resulting in analgesia and potential for opioid-like side effects. Lastly, kratom acts as a serotonin agonist, further contributing to euphoria, mood elevation, and relaxation. Because of its varied mechanism of action, kratom can produce an additive effect to prescription medications, increasing risk of side effects from other medications with shared sites of action. Binding affinities especially to opioid receptors, have been found to vary between traditional kratom and its synthetic alkaloids, resulting in the differences that are seen in tolerability and potency. The effects of traditional kratom are proposed to be dose-dependent, with doses below 5 grams producing a stimulant effect and doses greater than 5 grams producing depressant or opioid-like effects. Mitragynine alone does exhibit a ceiling effect on respiratory depression in animal models, contributing to its historically favorable safety profile. However, as doses increase, the likelihood of other side effects such as dry mouth, sedation, gastrointestinal distress, neurological dysfunction, and even hepatic energy does increase. Because of its binding activity at mu opioid receptors, there is potential for development of tolerance to kratom products, leading to increased regularity of use and dependence over time. Now that we've established a baseline of what traditional kratom is, let's talk a bit more about these new variants. The first is 7-hydroxymitragynine, or 7-OH, or 7-hydroxy. As we observed earlier, 7-OH can exist as a metabolite of mitragynine. It is also present as a minor constituent of the plant material, but only accounts for less than 2% of alkaloid content directly from the leaf. 7-OH is primarily produced during the drying process of kratom in smaller quantities, but can be produced synthetically in a lab at larger quantities. This metabolite has exhibited 10 times greater potency at mu opioid receptor binding in clinical studies, leading to concerns for respiratory depression and associated negative outcomes. Clinical presentation after consumption of 7-OH may include euphoria, sedation, or central nervous system depression. Product claims include boosting energy, improving focus and mood, providing relaxation, relief from pain or discomfort, and stress or anxiety reduction. Mitragynine Pseudoindoxyl, or MP, is the newest kratom product to hit the shelves. It is not present in the natural plant product and is formed either via metabolism in the blood or synthetically in a lab. MP has exhibited up to 100 times greater binding at mu opioid receptors in animal studies compared to traditional kratom, and it's also thought to act as a mixed agonist at other opioid receptors. This increased opioid activity leads to further concerns regarding potential for adverse events and negative outcomes. Many of these products are misleadingly labeled as kratom, despite having independent chemical structures and significant variance in potency. A recent analysis of 7-OH and MP products sold online found that 93% of these products were mislabeled or misleadingly marketed as traditional kratom, underscoring the risk of unintentional exposure to far more potent compounds. With the increased availability of these potent kratom variants comes the increased risk for misuse and abuse of these products. While mitragynine alone may have a limited ceiling on respiratory depression in some preclinical models, 7-OH demonstrates potent respiratory depressive effects in animal studies and has been implicated in human toxicity. Risk is thought to correlate directly to the dose consumed, with higher risk for central nervous system depression and respiratory concerns in products containing large amounts of 7-OH or MP. Co-ingestion with other substances has been documented to increase the risk of negative outcomes, as exhibited by recent reports of fatalities secondary to combining synthetic kratom products with alcohol or other designer substances. Between February and April of 2025, the National Poison Data System documented 53 exposure cases involving 7-OH, most of which were associated with intentional misuse. While most cases resulted in minor or moderate outcomes, several were considered severe. Notably, fatalities involving 7-OH and MP tripled between 2023 and 2025 compared to previous years, coinciding with increased availability of these products and further highlighting concerns regarding unpredictable potency. Symptoms of traditional kratom withdrawal are generally considered milder than opioid withdrawal, appearing within 12 to 48 hours of cessation and lasting up to 7 days. While parent mitragynine is thought to have a half-life of around 45 hours, The half-life of 7-OH may be as short as 5 hours, resulting in the potential for withdrawal symptoms as soon as 6 hours after the last dose. Available literature on traditional kratom withdrawal cannot be directly extrapolated to these synthetic variants since pharmacokinetic data on them is still fairly limited. However, severity of withdrawal symptoms can be expected to vary depending on the frequency of use and potency of the product. Products containing higher amounts of 7-OH and MP may carry an increased risk of producing a withdrawal similar to that seen with prescription opioids. Symptoms may include craving, low energy, fatigue, irritability, anxiety, depressed mood, restless legs, difficulty sleeping, gastrointestinal distress, cold or hot flashes, goosebumps, and muscle twitches. Regular use of kratom variants can produce physical dependence and withdrawal syndrome, meeting diagnostic substance use disorder criteria for some users. Management of kratom withdrawal is largely supportive care, with various different medications being used to manage symptoms. There is no FDA-approved treatment for the management of kratom withdrawal or dependence. However, given their opioid receptor activity, management principles for synthetic kratom withdrawal parallel those in opioid use disorder. 7-OH and MP should respond to opioid reversal agents, namely naloxone, in cases of overdose or respiratory depression. Buprenorphine and buprenorphine naloxone, both of which are FDA approved for opioid use disorder and dependence, have been used off-label for kratom withdrawal management. Buprenorphine, a high-affinity partial mu opioid receptor agonist, is thought to prevent kratom alkaloids, mitragynine and 7-OH from binding to opioid receptors. Several case reports have described the potential efficacy of these agents in kratom withdrawal management, including symptom relief, though there is no current data specific to its efficacy relative to the use of MP products. The FDA has issued warnings and stated that no kratom products are approved as dietary ingredients or drugs. DEA classifies kratom as a drug and chemical of concern, but has not placed the leaf in a federal schedule. Many states have opted to regulate kratom by enacting Kratom Consumer Protection Acts, which may include enforcement of minimum purchase age, product testing requirements, prohibition of synthetic product sale, or additional labeling requirements. Finally, some states have banned sale of kratom products entirely. Clinicians should consult state regulations as policies differ substantially and continue to evolve. The last question I hope to answer today is how this information affects clinical practice. Standard toxicology screens do not routinely detect kratom alkaloids, and as such, specialized testing, namely liquid chromatography and tandem mass spectrometry, is required to identify kratom and its variants. Aegis's updated kratom testing includes mitragynine, 7-OH, and MP in urine, enabling comprehensive detection and harm reduction. Based on available pharmacokinetic data, kratom and its synthetic counterparts are thought to be detectable in urine for up to 5 days after use. Testing in oral fluid at Aegis currently includes mitragynine and 7-OH, with a period of detection of up to 48 hours. As there is not currently any known marker to differentiate between traditional kratom and its synthetic variants, positive results should be thoroughly investigated and discussed with patients to determine both the source and to discuss potential for associated risk. Lastly, it's prudent to consider the potential for drug interactions, as mitragynine is a known inhibitor of multiple liver enzymes and may contribute to the potential for enhanced side effects and poor tolerability of prescribed medications. In summary, the emergence of high-potency kratom variants containing 7-OH and MP represents a clinically significant shift from traditional kratom use. These compounds exhibit markedly greater mu opioid receptor affinity and potency, resulting in increased risk for respiratory depression, dependence, and withdrawal severity comparable to conventional opioids. Limited pharmacokinetic data and the frequent mislabeling of products creates a diagnostic and treatment challenge for clinicians and care teams. Awareness of these differences is essential for accurate risk assessment, patient education, and effective management of toxicity or withdrawal. As synthetic kratom continues to evolve, collaboration among healthcare providers, toxicologists, and public health professionals will be critical to identifying, monitoring, and mitigating associated harms. Thank you so much for joining us for this educational presentation today. If you have additional questions, you're welcome to reach out at the phone number or email listed below. Our clinical team would be more than happy to help you.